My name's Dr. John Thompson, and I've been asked to talk about the use of the laboratory in investigating the unconscious patient. By way of background, I'm a clinical pharmacologist by training and a clinical toxicologist by interest, and also undertake quite a lot of general medicine. And as part of my work within the university and the National Health Service, for a number of years, I was director of the National Poisons Information Service in Cardiff, which is one of 4 units in the UK which advises on the management of poison patients and also attempts to set standards for their management nationally. So this is a picture of Cardiff Bay in Wales with the old Pierhead building on a nice bright sunny day. So I think considering the management of unconscious patients, I think we've really got to keep all our therapeutic and diagnostic options open. And it's very easy, particularly as a toxicologist, to think along purely toxicological lines. And I think we all have sort of nightmares of the unconscious patient where we potentially are actually missing a severe meningitis or cerebral infection, or even a severe stroke. So you need to keep your mind open, but this talk's really going to concentrate as part of the chemical pathology series on poisoning and some of the things we can use the lab for to help us in the management of poison patients. And I think using the laboratory to either look for a toxin or the metabolite of a toxin actually can play a really important part in the management of poisons with potentially serious adverse effects. However, when we look at actually how these investigations are used in different hospitals, I think particularly outside normal working hours, there seems to be quite a lot of variation. And even the availability of what assays and supporting tests are available does vary hugely, and this can present management problems. However, if you have ready availability, you can also have perhaps the other problem where tests are overused or misused, and that's not an efficient use of resources. So I think depending on what your local needs are, what part of the world you're working in, what the predominant types of poisoning are, and the resources available, it's worthwhile thinking about what's really needed, what's essential, what would be nice in doing this. So the talk will be split up into, I think, 3 parts. One is looking at some of the tests we have available that may help. The second is actually looking at actually how well the labs perform. Is the service fit for purpose? And finally, a few comments about poisoning surveillance and making sure we're aware of what's going on out there. So fundamentally, what do we need the laboratory for? Well, in the normal course of managing patients, we have a battery of what we tend to call, I hate the phrase routine, but routine readily available clinical investigations, like the glucose, like measures of renal function, liver function, acidosis. And sometimes we can take some of that basic information and try and get a bit more information out of it by looking at anion gaps or even osmolar gaps. Then we have the wider tests, like a full blood count. I'll try and illustrate a few drugs that might actually affect each of this myriad of tests that we get normally. And I think just as clinically, when we're looking at a poison patient, we might think about toxidromes. So, for example, a patient with pinpoint pupils, slow, shallow respiration, decreased level of consciousness might make us think about opioid exposures. I think we also need to think in a similar way about patterns of analytical changes that, while might not be absolutely diagnostic, might actually point us towards or away from a particular agent as being a possible cause of the patient being seriously unwell. Or, equally important, trying to pick up the patient who may appear fine now, but nevertheless can actually go on to become seriously unwell. So you might think about poisons like paracetamol, which can cause severe fatal liver damage, classically 48 hours, 72 hours after exposure, where the patient might appear perfectly healthy on arrival at hospital, but nevertheless could have taken a fatal dose. So I think we're using these tests to try and confirm the diagnosis and to anticipate problems and to help us find solutions. So, and this is the only slide where I've put the writing in red. I think any unconscious patient, you really have to think about checking the glucose. It's fairly easy to remedy, and left untreated, severe hypoglycemia can actually cause brain damage. Markers of renal failure, well, if we have a mental sort of shopping list in our minds of poisons that can cause renal failure, that may help us narrow the diagnosis down. But also to be aware that obviously if a patient has been unconscious, they're not eating and drinking, so they may become dehydrated, particularly in hot climates. And so we're treating the consequences of being an ill patient, being an unconscious patient, in addition to the more direct effect of the poison. Similarly, with a patient with deranged liver function tests, we can think more directly about hepatotoxins. So going back to the list I put up earlier, full blood count, well, there may be drugs which can depress bone marrow. So, for example, in the UK, a lot of methotrexate is prescribed on a once weekly basis, but nevertheless accidents still happen where patients are administered on a daily basis, causing bone marrow suppression. Lots of poisons will upset the electrolytes. Beta blockers, for example, can depress glucose. And thinking about calcium, it's not pathognomic for ethylene glycol poisoning, but ethylene glycol gets metabolized to oxalic acid, which can combine with calcium, produce calcium oxide crystals, which can cause kidney function. So if you have a patient who seems to have renal impairment, which is new, and a low calcium, and you're suspicious about ethylene glycol poisoning, maybe from illicit alcohol distillation, or in the UK from its use as antifreeze, they're soft indicators, but might just help you confirm or think about a picture which leads you to the conclusion that one or other toxin might be present. Liver function tests, I've touched on. Paracetamol is a major problem where I work in the UK, and I'll touch on the anion gap and osmolar gap as being markers for things like toxic alcohols. The arterial blood gases, I think, are really very useful, and again, both metabolically in terms of the pH, and also as a measure of ventilation and effective gas exchange. Similarly, the creatine kinase might be elevated in a patient who's been unconscious. They might have pressure necrosis, rhabdomyolysis, and in turn, the pigments from the muscles released in rhabdomyolysis, the myoglobin, can get deposited in the renal tubules, and that can go on to cause renal failure. So that thinking about the possibility of muscle damage, using the lab to help us by measuring a CK, might make us become more aggressive with the use of intravenous fluids, which is very often all that's needed to prevent a subsequent unavoidable kidney damage in a patient who's been unconscious for a while. So what about the specialist laboratory assays? Those are the ones that might be more readily available. Well, I think actually it's really helpful to confirm a diagnosis if that diagnosis is in some doubt. And indeed, even if clinically the diagnosis has been made, it may actually lead to thinking about further investigations, maybe monitoring the kidney function in a few days' time, maybe influencing the use of antidotes, a number of which the need for antidotes or their use will depend upon the concentration of the toxin present. If it's available with very, very high levels of toxins for some chemicals, you could think about hemodialysis or other extracorporeal methods of removing the toxin from the system quickly. And indeed, after successful treatment, it can confirm that the toxin's no longer there, or no longer there in toxic levels, and allow you to stop treatment and move forward. Similarly, you could actually use the labs not to determine high levels, but maybe to determine when a level of a drug's come back to a therapeutic range, as to when to reinstitute chronic therapy. So, for example, if you had a patient with bipolar disorder who's maybe on lithium as a mood stabilizer, and they've got dehydrated, the kidney function's gone off, those levels can go very high. as well as treating the acute poisoning, it can be really important to reinstitute that long-term treatment for the patient as soon as it's practicable. I think the other one, which is becoming a more frequent question, is phone calls I've had, for example, from intensive care units about a deeply unconscious patient where brain death is suspected. And people are wondering, actually, can you undertake the brainstem death tests, which you can't do in the presence of cerebral depressants. So you need to make sure there's no toxins on board before doing that, or consequently identifying a drug, being able to predict using its basic clinical pharmacology and half-life when it should be out of the system for similar decisions, and indeed advising on the use of potential organ donations afterwards. And this is really the basis of another of the talks in this series, but to think about maybe the use of some of these results for medical, legal, or forensic reasons in deciding what may or may not have contributed to harm. Some of it can be long-lasting, or even death. So finally, I think in terms of the general principles, patterns of poisoning change. They change as drugs and toxins become available. They can change as a result of legislation. So I think the specialist assays have a role in trying to pick up these patterns of change. So I'll show some figures for the epidemic we had, which is now, I think, settling down, of novel psychoactive substances, which needed special schemes and special analytical techniques to detect new substances. And indeed, it led to new legislation and how we actually manage legally these recreational drugs within the UK. And I think it can also be useful in terms of more on a research basis. But for example, some of the organophosphorus pesticides are substantially more likely to cause death than others. And by understanding the pattern of death and which OP pesticides were available, one might be able to legislate to keep the effective but safer pesticides on the market, and maybe actually not legislate to keep some of the ones which are more likely to lead to death. And I think, unlike forensic toxicology, the patient is dead, time to look for things and think about the assays very, very carefully. In the clinical practice, you may actually want to, or be prepared to, sacrifice specificity of the assay or even accuracy in order to get the advantage of speed and convenience. So having a good enough result, maybe it tells you it's a benzodiazepine, but not which one. A good enough result to influence the clinical management, even though it's not necessarily the whole answer. It's better to have an adequate result in time than a perfect result too late. And I think I'd encourage all of you to actually get used to talking to labs which are undertaking these assays, because all assays have limitations, and it's really useful to be aware of what these are. And I think one of the classic ones is a substance might be present, but if it's below the detection limit of the assay, it might just get reported as being a negative result or not being there. And in UK practice, this historically has been an issue in regards to paracetamol poisoning. So here would be the nomogram used in the UK for deciding on whether an antidote for paracetamol poisoning should be used. And in this graph, the treatment line starts at 100 milligrams per litre at 4 hours, and then that concentration halves every 4 hours. And if you're above the line, you'd get treatment, and if you're below the line, treatment wouldn't be indicated. But if you have a laboratory which has a detection limit of 10 milligrams per litre, for patients presenting late on, you might be actually missing. And for labs which have a level of 20 millimoles, which wasn't uncommon, patient presenting after 12 or 13 or 14 hours might actually have benefited from treatment, but the laboratory wouldn't be picking that up. So you need to understand the limitations of the lab. When it comes to the osmolarity of the blood, that really reflects the number of particles in solution. And we can estimate that from some of the results we routinely get back from the laboratory. However, if you actually then measure the osmolar gap by looking at freezing point depression, it's a characteristic that the more things you have in solution, the more the freezing point is depressed. You'll find that there's an apparent gap between what you're actually measuring and what you're estimating from the normal blood results. That's osmotically active. So we can effectively estimate the osmolarity, and we can work this out looking at the urea, the glucose, the sodium. And then it's a characteristic that the freezing point of a liquid depends on the number of particles in it. So if you look at the ability of that freezing point to become depressed, that will give you a measured osmolarity, telling you how many particles there are, and the difference between your estimate and the measured leads to this osmolar gap. So being pedantic, you can multiply the sodium by 1.86, add the urea, add the glucose, and divide it all. Or in the real world, it's about twice the sodium plus the urea plus the glucose. And that would give you a gap which is completely normal between 5 and 15 milliosmoles per kilogram of water. If you do that calculation and it's bigger than that, that's telling you there's something else in the bloodstream at the time that you're not measuring. So that could be something like ethanol or ethylene glycol, something else which is contributing to an increased osmolarity, which isn't showing up by the simple calculation. Similarly, the anion gap is accepting that plasma's got positively charged particles and negatively charged particles, but is overall neutral. And the gap is the difference between the measured anions and the measured cations. And that gap is usually due to negatively charged proteins like albumin or fatty acids, or some of the inorganic anions, sulfates, phosphates. So if you take the sum of the positive anions, the sodium and the potassium, take away the commonly measured negative anions, bicarb and the chloride, that gives you an anion gap. And in normal circumstances, that's 12 to 16 millimoles per litre. If you do that calculation in a poison patient and that gap is bigger, it's telling you that there are other charged particles there which are not normally there, or are there in greater quantities. So if you think about ethylene glycol poisoning, a toxic alcohol, if you swallow ethylene glycol, which is quite a sweet tasting liquid, initially, as that gets absorbed into the bloodstream, the ethylene glycol itself is going to contribute to the osmolality of the blood, and will increase that osmolar gap. As the ethylene glycol gets metabolized, the osmolar gap falls, but the metabolites, for example, glycolic acid, oxalic acid, all contribute to an anion gap. So what you're likely to see is an osmolar gap to start with that gets smaller, and then an anion gap that actually then gets bigger with time. Again, caveats in terms of how we can actually deduct or not deduct the presence or absence of toxins, given the range of what's normal. So if you have 50 milligrams per deciliter of ethylene glycol, that's sufficient to raise your osmolar gap by 8 or 10 milliosmoles per kilogram. So the presence of an osmolar gap supports the diagnosis, but actually you can have a normal osmolar gap and still have substantial quantities of ethylene glycol on board. So you need to interpret the test rarely. So the presence of a gap can support the diagnosis, and the absence of gap doesn't actually exclude it. Sticking with ethylene glycol, looking at the anion gap, the main component of the gap in ethylene glycol poisoning is glycolic acid, and that can increase it. And the pattern we sometimes see in the UK is people have been out drinking, so as well as taking the ethylene glycol, they might also have ingested other alcoholic drinks, ethanol. And actually, it's probably a good thing in that one of the antidotes for ethylene glycol poisoning is in fact ethanol, ethanol competes with the same enzyme that metabolize ethylene glycol. And with ethylene glycol poisoning, it's the metabolites that are toxic rather than the parent compound. So ethanol will delay the metabolism of ethylene glycol. That's good. It makes the patient a bit less poisoned to start with, at least. But as that inhibition wears off, that anion gap might still appear, but appear later on than you might otherwise expect it to. And what about the use of these other tests? Well, I think this is quite a good one just to think about supporting evidence, not actually diagnostic, but nevertheless helpful. So I've said that oxalic acid can combine with calcium, and this produces calcium oxalate crystals. And this is really part of the problem with ethylene glycol poisoning, in that they can get deposited in the renal tubules, actually the myocardium and the brain, and then lead to renal failure. So if you have a patient in whom you suspect ethylene glycol poisoning, who came in with a raised osmolar gap, who's developed a raised anion gap, and has now got a low calcium, that's going to make you more suspicious. Similarly, if the patient was known to have normal kidney function, or maybe on arrival the kidney function was normal or slightly deranged, and it's now the creatinine is going up rapidly, again, that would fit with this pattern of poisoning, this toxidrome of ethylene glycol. And I think also if you measured a CK, a creatine kinase, that again could just give you an indication that maybe some of these crystals are being deposited elsewhere and causing muscle damage. And again, the muscle damage can then release myoglobin, which can then also contribute to impaired renal function. And finally, one of the oddities, and it comes back to what I was saying about talk to your lab, get used to the limitations and, if you like, the quirks of the assays, in that there are a number of blood gas machines that will apparently report a very high lactate when the patient doesn't look that sick. And some of them actually interpret the glycolic acid from the metabolism of ethylene glycol as lactic acid, and will report a falsely elevated lactate. So that's just one of these sort of things where the lab giving a false result actually can be quite helpful. But you need to know whether your blood gas machine is one of those gas machines that actually has this particular characteristic. So how should we use the lab to try and be efficient and yet get what we need to? And I'm very conscious that resources vary tremendously depending on where you work, whether you're in a remote rural hospital or in a big city hospital. So, for example, I've recently been doing some work on a fairly remote island, and the availability of tests out of hours is very different from the availability during the day, and special tests may have to get sent off in a boat or a plane to get assayed. So I'm conscious that whilst the perfect needs might be similar, the ability to actually investigate is very different in different circumstances, and we have to just work around that and be pragmatic about it, really. So I think we need to actually, particularly when they get people up and out of bed at night, decide, do we really need the urgent answer? However, certainly in the UK, I think our feeling is that anywhere where severely sick patients are being admitted 24 hours a day, there are at least some investigations that should also be available within that same time frame. And we've tried to do this actually in conjunction with experts in their field. So ourselves, as then was the National Poison Information Service and the Association of Clinical Biochemistry, whose staff actually do the assays and report the results and get them to us. And we wanted to think about what assays we thought should be available, timeliness of results being available, and then try and come up with national guidelines, which we hoped would support hospitals in justifying requests for services, particularly when resources are tight. So we produced a couple of these position papers, and in these papers we divided the results as to what we needed sort of more urgently or less urgently. So we thought, what are essential common laboratory investigations and what are specific toxicological assays, and how quickly we wanted them. And I think, and this can be a worthwhile exercise, just think about your local patterns of poisoning. because, living in the real world, these have to affect the local pattern of poisoning. So if you were somewhere that saw a lot of organophosphorus poisoning, you could think whether a cholinesterase assay might be helpful in the management or not. Paraquat we see very little in the UK, but nevertheless it can be helpful to identify it as a cause. So I think it's a good sort of thought experiment, if you like, to think about actually what might be useful in your own local circumstances. So we split them up into 24 hours a day availability, or other tests that actually might be needed more infrequently, could be done on a regional basis or even a national basis. And that concentrates resources and helps with audit and quality control. So 24 hours a day or infrequent. And in my practice, these are poisons that we thought actually being able to measure might actually be useful with a fairly rapid timescale. And basically, it's a fundamental question: will the results alter my management? So if a patient's been in a house fire and they had carbon monoxide poisoning, and that's combined with hemoglobin with carboxyhemoglobin, that could help us actually determine to put them on high flow oxygen to try and decrease that carboxyhemoglobin and improve oxygen delivery. Digoxin, again, there's an antidote, an antibody available for digoxin, and knowing the concentration can be worthwhile in deciding, does the patient need an antidote if it's available, and what dose of antidote would you want to give? Similarly, for lithium, patients on long-term lithium therapy, again, it can help inform the choice of whether are they poisoned in the first place? If the renal function's normal, maybe we can just rehydrate them and let the patient eliminate the lithium by themselves through the urinary system. Or if it's severe poisoning, whether we might be contemplating actually the need for hemodialysis. Similarly, for methemoglobin forming agents, and you could think about some of the nitrates and fertilizers and such like, is the methemoglobin a sufficient concentration that it merits actually giving an antidote? Paracetamol I've touched on, very, very common in the UK. And for acute paracetamol poisoning, our decision-making process is really heavily driven by the presenting concentration. Paraquat, in fact, that's virtually impossible to get done in the UK nowadays. But again, qualitative test, is it there, isn't it there? And there's a more specialist assay, actually a quantitative test. Salicylate, we don't see so much in the way of aspirin poisoning these days, but nevertheless, actually knowing the patient has a high salicylate concentration can really inform the management they need for what can be a very serious and quite difficult to manage poison. Similarly for theophylline overdoses, patients who've maybe taken large amounts of their own or somebody else's medicine. For the infrequent assays, they're likely not to be available in your own hospital, may involve sending a sample off somewhere else. And I think it's worthwhile in it knowing how to be able to request these tests. There's no point having a test if you don't know how to use it. And I think it's also in these cases really worthwhile talking to the laboratory first, deciding actually is the test really necessary? Are there any special circumstances in how you need to send it off? What tube do you take the sample with? How are you going to get the results to the lab? And, where's the best place for the lab to then get the result back to the person looking after the patient, given it may be a different person the next day, the day after, who's doing it. And within the UK, we're fortunate we've got the National Poison Information Service, who are able to advise and offer advice on this. And we also have an online database, ToxBase, which is available either by subscription, or we have a ToxBase app, for which there's a cut down version, which is available for about $7 or so, which contains information on the management of common poisons. So these in the UK are the specialist or infrequent assays that we thought would be helpful. And as you can see, they're split really into assays for therapeutic medicines, carbamazepine, phenobarbital, phenytoin, thyroxine, some heavy metals, and then one or two rather more sort of specific one. And I put tox screen in quotation marks because I think that varies depending on really what you want to use it for. So the tox screen, one of the ways that it's used locally in Cardiff would be for drug abuse screening. And it might be actually to confirm that somebody actually has been taking illicit drugs of abuse before they go into a therapeutic program, which might, for example, prescribe them methadone. Methadone being a long-acting opioid compound, but has considerable market value if the patient doesn't take it and chooses to sell it. Or conversely, it could be a patient who's being prescribed methadone, and to actually ensure that they're actually sticking with the program and are no longer taking illegally bought, for example, heroin. And then I think, we need, as far as possible, to standardize actually how we report the results of these tests. And I think our feeling is that actually we should really be giving these in mass units per litre, with the exception of a few things like iron, lithium, thyroxine, where there are more conventional units that are well used. And if laboratories are continuing to use molar units, they should also actually give the results in mass units. In my hospital at one time, there were 3 different ways of reporting ethanol concentration, to be milligrams per deciliter, milligrams per litre, or even millimoles. And they're all sufficiently close together as to be plausible, but clearly, at least one of them has a 10 times error in interpreting the results, and that's going to be really important. It can be the difference between a potentially fatal dose and a dose that really wouldn't be of great concern. So the title I was given actually wasn't just about the unconscious patient. It talked about evaluating laboratory investigation. So we actually undertook to look at laboratories to see, actually, were the labs doing what we, in our perfect world, hoped they were doing. So we surveyed every single hospital, big hospital in England, Scotland, and Wales, and basically tried to look at the availability of the assays that were available in the real world as to what we think should be available. So we asked the labs, do you do this Monday to Friday? Do you do it 7 days a week? Just working hours, night time, and so on. And where assays couldn't be undertaken locally, we asked where they were sent to, and importantly, how long it would take to get that result back. Would it come back in a meaningful time? And relatively good news, the assays which we thought we wanted readily available were pretty well readily available, the exception being for paraquat. And so that was quite reassuring. However, when you looked at the group 2 assays, the exception of 3 anticonvulsants, really their availability was very much less. And the availability locally makes a big difference. So digoxin was pretty much always available. The results came back quickly. And for ethylene glycol, almost universally, it was sent elsewhere. And I think at the time there were a couple of labs in the whole UK that were measuring it. And in terms of the time it took to get the result back to the user, sometimes it was quite quick. But I'd suggest if the results coming back after 3 days or 4 days, that's too late to be meaningful for the management of the patient. It's not really adding anything. You've either decided to treat them for ethylene glycol poisoning, or if you haven't, they'll have got worse or they'll have got better. So a result that's too late may be really very little help for the patient, although it might be useful in terms of forensic analysis, which we'll discuss in the other talk. So in the UK, these group 1 assays were widely available in quite a timely manner. But the reality is that the specialist toxicological assays, some were barely available. When they were available, the results could be delayed, and the assays which actually could influence the use of antidotes were often not available sufficiently quickly to do that. And that really means you have to rely on your clinical judgment. So go back to what's happening with the patient, take a really good history, examine the patient, thinking about toxidromes. And this isn't just a one-off process. It's not have a look at them when they come through the door. In the management of poison patients, it's an iterative process. It's actually look at the patient, make a working diagnosis, make a management plan, review the patient. Is the management plan working? Do you need any other investigations doing again? And you're going back and actually challenging your own thinking. So I think there's considerable room for improvement in the availability of analytical support, even in a country like the UK. And I think we really do have to think about prioritizing what's needed, and how that's going to be done. And that can present huge challenges. It may be that analytical facilities available within the same organization. It may be that actually they're available within a different organization or even an academic institution. And so, I would encourage thinking about collaborations between aspects of the health provider, academia, and other people with the techniques for doing this. And then, I think our hopes were that by thinking about what we needed and producing guidelines, this might actually produce more effective use of the lab. And I think to some extent it's done that. I think our other hope was that by having agreed national standards, it would help hospitals in making the argument, in developing services, and indeed where services were already available, actually helping maintain analytical support when there may be other pressures to spend money and use scarce staff resources elsewhere. Unfortunately, I think in the UK that's not been the case, and the availability, certainly for specialist assays, is decreasing. It certainly has decreased over the last decade. And then I think finally, just to sort of move away maybe from the individual unconscious patient, is to actually think about maybe how we can use the labs to help actually identify trends in severe poisoning, so that we can tailor services, tailor resources, and even actually tailor legislation to actually try and maintain the population health of wherever it is that we're working. And I think fundamentally you can think about these questions as, how do we know what's out there? What are people taking? And on the right, you'll see pictures of these so-called novel psychoactive agents. I mean, they were variously known as bath salts and all sorts of other things. Quite, incredibly well marketed, nice, pretty packages. Some of them suggesting don't take it if you're under 18. Others saying not for human use. They're all not for human use. But the pattern of poisoning in the UK is changing really quickly. So it begs the question of how actually can we use the lab to monitor these chemicals, maybe try and develop treatment strategies. If we don't know what we're treating, all we can run on is the toxidrome and symptomatic treatment. And even actually, is our regulatory framework up to coping with these trends? And these are some figures that show the fairly rapid onset of these novel psychoactive agents becoming available within the European Union. And this EMCDDA report, which monitors drugs and drugs abuse within the European Union, makes really quite interesting reading, picking up the trends. And as you can see from the green bars, there was a huge increase, even over a period of 5 years, of synthetic cannabinoids coming on the market. And some of these cannabinoids are incredibly potent, and we were seeing patients coming in with patterns of poisoning that we frankly hadn't seen previously. And unless we're actually using analytical services to look for new compounds, and that again is a huge sort of forensic challenge and needed sort of specialist equipment, we're not being able to think about, as poison information people, what advice we can give on treatment, and the regulators really won't know how to regulate stuff. And so one of the schemes that came in, and this was one run from the building I was working in, so-called weddinos.org, let emergency departments, hospitals, and nightclubs and the police on a voluntary basis, and individuals who'd bought the substances, send the substances in anonymously to be tested. So they'd send in maybe a packet that looked something like this. They'd fill in a form saying what did they think they were buying, because very often what you think you're buying, what you get aren't the same. What did it look like, and so on. Did they want to use it as a bodybuilding aid, as a psychoactive substance? They could tell us what they were expecting it to do to them or for them, and what it actually did. And these samples were coming in by the post, and they'd be analysed, and the results are put on the website, so that everyone can then see actually what is in that particular pack, bearing in mind what's in it this week might not be what's in it next month. But it did actually enable the results to go up, together with public health advice on risk reduction. So people actually could take a more informed choice of what they were doing. Even advice is actually this stuff doesn't have an immediate onset. It can take half an hour or so. So if you've taken a dose and you think it's not working, for Pete's sake, don't go and take another dose. Otherwise you're only getting a double hit. So this sort of new analytical approach has been really helpful in trying to pick up what have been huge changes in the pattern of poisoning. And because of the huge number of new compounds coming up, rather than playing catch up and trying to legislate each individual substance in the UK, that the law was changed, and substances were regulated by the intent or the ability to have a psychoactive effect. And in terms of the criminality, it was really put back on those who were importing or selling the drugs rather than actually being in possession of them. So I think in conclusion, I'd have to say that laboratories can have an important role in the management of the poison patients. And I think, taking into account local circumstances, we need to ensure that appropriate assays are available in a timely manner, and also to accept that analytical services have a wider role in protecting public health. So thank you very much for listening to me. That's a reference for the paper I was talking about. Thank you.